Yeah, good afternoon, ladies and gentlemen. Thank you for the invitation to talk about replacement augmentation therapy locally to the lung. And what I would like to do is not only talk about alpha-1 antitrypsin deficiency, but also some related other diseases. As we all know, and as you all may know, there is not only the emphysematic situation, but the airways are chronically infected and are thickening and building bronchiectasis. And in this study, it was shown that almost all patients had bronchiectasis on CT scans. These are enormous dilatations, which are of course not present in each patient. In about 1/3 of these patients, sputum production was in such a way that it was called clinically relevant bronchiectasis. So this is, in addition to the changes which gives the emphysema in the lung, an important change which can also be found in several other diseases, rare diseases, for example, in cystic fibrosis. This is another lung disease where patients very early on develop bronchiectasis already at age 3 months. About 1/3 of the patients have these bronchiectasis on CT scans, which may develop and which are also very much in a situation like alpha-1 antitrypsin, primary alpha-1 antitrypsin deficiency, because when you measure antitrypsin levels here, they're also low, and neutrophil elastase is a very strong factor which predicts the development of these bronchiectasis. So there is a common scheme which is governed by the fact that within the airways and also in the surrounding areas, there is free elastase at a very high concentration, leading to these structural lung problems. So it is, of course, thought to bring directly alpha-1 antitrypsin into the lungs to prevent these consequences. And there are currently 3 studies, or 9 studies in total, in all the different conditions, 4 in alpha-1 antitrypsin deficiency, 4 in cystic fibrosis, and 1 in another disease which is observed after transplant, which has a very similar logical sequence. And I will briefly go through some of these studies. The oldest evidence that we have is almost 30 years old, that inhaled alpha-1 antitrypsin at very low doses compared to what is given IV, it's less than 1/10, is able to neutralize the elastase in the airways and to achieve levels which are necessary and which can, because the protein is functionally intact even after inhalation, normalize the elastolytic activity in the lung. There were no side effects observed, and with inhalation, it is a big problem to deliver the medication into the lungs without loss outside in the upper airways or in the throat or somewhere else. And for this, there are some additional inhalation devices in addition to the nebulizer, which you may all know, which are so-called smart devices, which deliver the aerosol right in the face when it's used during inspiration. So during the expiration, when you exhale, no drug is delivered, and by this, the amount of drug can be very high, which is deposited in a short time into the lungs. As you can see here, this has been tested by radioactively labeled drug, and you can see central deposition and peripheral deposition in the peripheral airways. And what you can observe is that about 70% of the drugs that has been put into the nebulizer is brought into the airways, and this is independent whether these are healthy people people with alpha-1 antitrypsin deficiency or CF patients, and it goes down to very low lung function levels where this technique still works. So such a technique was used in the study to determine if there is a difference if you deliver the alpha-1 antitrypsin directly into the large airways, or if it is much better to deliver it more into the periphery of the lung. The results of this study are that there was no difference. So it doesn't matter whether you really take great care to deliver it into the periphery compared to the normal, usual inhalation as it is done most frequently. When you go into more details in these studies, it could also be shown here that alpha-1 antitrypsin is delivered at a specific, or can be increased to a certain amount in the lungs of the patients after 2 and 4 weeks, and there was a very small effect on the free elastase activity, which is depicted here. However, this was in sputum, so because sputum contains a lot of neutrophils, and there was a small drop which is marginal or may appear marginal. When you look at the numbers of neutrophils which could be recovered, these were also going down in this pretty short period of 4 weeks. In the same line, inflammatory markers and bacteria went also down. Lung function did not change over this time period. There is another study in alpha-1 antitrypsin deficiency now, not in this, the former was in cystic fibrosis, which addresses a similar question. The study has been just a couple of months ago concluded, so it is too early, or the results are not yet available. It's too early to report about these things now. The second study in the same line in less patients was done. Here it was the target was not so much the physiological effect on lung function, but more on the inflammatory variables which were to be observed. Another study, or similar, a big study, is the largest study, which is most promising, has enrolled 339 patients, which really started a year ago almost, or more than a year, 1.5 years ago, which can really prove if this therapy, inhaled therapy, will be working or not. And there were some intermediate results from this study. So it was tolerable, the tolerability was very good, the safety was very good. After 200 patients were included for 1 year. However, it will take another year or two until the results of this most important study for the patients will be obtained. So I think in summary, I think it's important to stress that alpha-1 antitrypsin does not only play a role in primary deficiency, but may also play a role in other diseases where very similar mechanisms are observed. And inhaled alpha-1 antitrypsin for lung disease is a viable and safe option, as far as we know, to stop these processes in the lung. And there is technology available which allows good delivery to the lungs so that it is possible to neutralize the elastase which is present, and we are eagerly waiting for the results of the large studies, one of which I think, at least for alpha-1 antitrypsin, will be available soon. Thank you very much.